Welcome to this educational course on anaphylaxis organized by OmniCuris. I am Antonella Muraro, head of the Food Allergy Referral Center Veneto region at the Padua University Hospital in Italy, and the co-author of the European Guidelines of Anaphylaxis published recently in Allergy 21. I am the coordinator of this educational course on anaphylaxis. In this educational course on anaphylaxis, we have planned 4 modules tackling the most critical area for anaphylaxis. First of all, vaccination and anaphylaxis. The second webinar will tackle the understanding of anaphylaxis mechanism and why adrenaline is important as first-line treatment. In the third one, we will tackle the management of anaphylaxis in the community, and in the fourth one, we will focus on critical environments who put the patient at risk for anaphylaxis. The overarching aim of this educational course on anaphylaxis is to promptly recognize anaphylaxis and understanding the risk at any settings in order to promote increasingly efficient and patient-centered care, so that the patient can get the treatment they need, how and when they need it. This is the introduction to the second module, which is understanding anaphylaxis and the treatment as a first line with adrenaline. I will give you some clues on how adrenaline is standard of care of anaphylaxis, what are the gaps that we have so far in managing anaphylaxis, and the role of adrenaline autoinjectors. Adrenaline is clearly identified as a first-line treatment for anaphylaxis in all guidelines, and intramuscular adrenaline is recognized by all international guidelines as a first-line treatment. The World Allergy Organization, as well as the World Health Organization, WHO, classifies adrenaline as an essential medication for the treatment of anaphylaxis, even in vulnerable patients, pregnant women, infants, elderly. And adrenaline, life-saving mechanism of action, helps to reduce the risk of hospitalization and death. But what is the usual scenario that we have when the patient with suspicion of anaphylaxis get access to the emergency department? Usually, she doesn't get adrenaline. So, should they give adrenaline? No, if the patient is not collapsed, the usual drug is formed by steroids. And in order to help the emergency physician to catch as many anaphylaxis cases as possible, up to 95% with 95% of limit of confidence, in 2006, clinical operational criteria have been established by NID, NIH in the US, together with a big patient organization. There are 3 main criteria. The first one is anaphylaxis is highly likely when any one of the following 3 criteria is fulfilled. First criteria, sudden onset of illness, minutes to several hours, with involvement of the skin, mucosal tissue, or both, and sudden of respiratory symptoms and signs, and sudden reduced blood pressure. But in order to catch also those cases who may be not immediately recognized by the emergency physician, in the second criteria, the clinical history of the patient have been included. For example, after exposure to a likely allergen of other triggers, onset of some set of symptoms, skin mucosal, with respiratory symptoms, or respiratory symptoms with sudden reduced blood pressure, or sudden respiratory symptoms with sudden gastrointestinal symptoms. The third criteria is devoted to that minority of 10 patients in whose the only symptom for anaphylaxis is a sudden drop of blood pressure after exposure to a known allergen for that patient. These criteria have been established in 2006. What happened since then? We have huge gaps in managing anaphylaxis due to the lack of recognition, the lack of standardized diagnostic and treatment pathway worldwide, lack of education and training on adrenaline administration, and lack of precision of adrenaline autoinjectors, even considering the autoinjectors differ according to the brands and are not the same. So across all stakeholders who surround the patient with anaphylaxis, there is a huge fragmentation. What about the recognition of anaphylaxis? This is a picture of the emergency department in a descriptive study reviewing the electronic medical records of patients who presented with symptoms consistent with anaphylaxis. Out of 1,341 cases reviewed, 60 cases met criteria for anaphylaxis, but only 23% were correctly coded, with 77% were incorrectly coded. So despite the published diagnostic criteria, misdiagnosis of inaccurate coding of anaphylaxis is common. And this is also replicated in the study of the US National Electronic Injury Surveillance System, where 57% of likely anaphylactic events to food allergy didn't have a diagnosis of anaphylaxis at the emergency department, and also at the retrospective studies in Rochester, Minnesota, where 25% of 211 anaphylaxis cases were given less specific allergy code. Again, misdiagnosis, inaccurate code of anaphylaxis is quite common. And this is reflected in the lack of standardized adequate treatment, both in adults and in children. If you consider the NORA registry, which is a European registry across Europe, they included 1,363 children and adolescents referred to tertiary allergy centers in 10 European countries, and centers were asked to include their most severe cases. That means those with a known elicitor, with grade 3 symptoms admitted to intensive unit care, or grade 4 symptoms of fatal reaction. On the right part of the slide, you see the professional treatment of anaphylaxis, where you have steroids from the bottom, antihistamine oral route, beta agonist, getting back to adrenaline, IV, and inhaled. Overall, only 29% of physicians used adrenaline, and only 15% of physicians used intramuscular adrenaline. Quite a disappointing picture. But what about the education and training of health professionals? Most doctors are unaware of how to correctly administer adrenaline. A convenient sample of hospital doctors potentially involved in the treatment of anaphylaxis in two national health services, the District General Hospital Trust in England, were interviewed by direct questioning in 2009. And as far as administration route is concerned, 24.4% have considered the wrong route. And with regard to intramuscular adrenaline, adrenaline, 57% would use the wrong site, and with regard to the dosage, 73.2% would have used the wrong dose. So only 13% of doctors knew correctly how to dose adrenaline, the route, and administration site. And maybe the use of autoinjector would circumvent at least two of these issues, ensuring correct dose and correct route. This is if health professionals have a huge lack of knowledge in administering autoinjector, their patient cannot do better. And autoinjector are underused in the emergency management of anaphylaxis by lay people. You see here that 78% of patients would have used oral antihistamine, 52 steroids, beta-2 agonist 28, and only 12% would have used autoinjector, and only 14% would have prescribed an autoinjector. So autoinjectors are underused in anaphylaxis emergency, even when prescribed. There are some lessons from the registry of anaphylaxis fatalities which show the lack of prescription and the failure of administration of adrenaline in a timely manner closely related to the death of the patient. Out of 92 anaphylaxis deaths, 47 had known or suspected allergy, but only 18 had been prescribed an autoinjector and only 10 carried it. And with regard to the timely administration of adrenaline, 92 anaphylaxis deaths, 21 received adrenaline prior to the cardiac arrest, and 71 did not receive adrenaline prior to the cardiac arrest. And this is even striking. Consider where the location of anaphylaxis episode. Out of 40 food anaphylaxis death, 14 happened at home and 20 outside home. So they needed an autoinjector. So more than 60% of those with known or suspected allergy were not prescribed an autoinjector, and more than 75% received adrenaline too late. That means after cardiac arrest. In the recently published guidelines of European Academy regarding emergency management of anaphylaxis, the ACI task force recommended promptly using intramuscular adrenaline as first-line treatment of anaphylaxis, as adrenaline covers all the symptoms. And in addition, we suggest to use adrenaline autoinjector for the first-line treatment of anaphylaxis, keeping in mind that the pharmacokinetic data should be provided for each adrenaline autoinjector product, as they cannot be regarded as interchangeable. And the local doses and adrenaline autoinjector brands availability may vary according to countries. And I would like to remind that the European Medicine Agency, EMA, in 2017 recommended to prescribe 2 autoinjectors at any patient at risk. So what are the questions that we are asking to our outstanding speaker today? What are the mechanisms of anaphylaxis and how adrenaline can counteract them? When and how to administer adrenaline, and what is the self-management of an acute episode of anaphylaxis, considering the differences among brands of adrenaline autoinjectors. And it is my pleasure to introduce to you Professor Graham Roberts, Professor and Honorary Consultant at University Hospital of Southampton, NHS Foundation Trust in the UK, and President of the British Society of Allergy and Clinical Immunology.
Hello, I'm Professor Graham Roberts. I'm going to talk to you about anaphylaxis and why adrenaline is the most important first-line treatment for anaphylaxis. So I'm a professor and consultant in paediatric allergy and respiratory medicine. I work between University of Southampton, the hospital in Southampton, and the David Hyde Centre in the Isle of Wight. I have a couple of disclosures around generating this webinar. So I'm going to talk about anaphylaxis and its pathophysiology. Then I'm going to spend a little bit of time thinking about the recognition of anaphylaxis and differentiating severe and mild allergic reactions, and then think about which patients actually risk of developing anaphylaxis. Then talk a little bit about treatment, and then importantly, self-management. So hopefully by the end of this webinar, you'll be able to recognize the signs and symptoms of an anaphylactic reaction, understand why adrenaline is the treatment of choice, and just be able to describe how to manage anaphylaxis. So what is anaphylaxis? There's a lot of definitions out there. Simple is better in my viewpoint. So the one I like is a severe, life-threatening, generalized or systemic hypersensitivity reaction. And I like it because anaphylaxis is more of a syndrome than a very specific diagnosis, and that, I think, captures it. So typically, the pathophysiology is IgE mediated, so it's a type 1 hypersensitivity reaction. And the usual suspects in kids is peanuts, tree nuts, egg, milk. Older individuals, who then start to see other foods, and for that matter, other triggers such as insects and medication. In terms of incidence, it's low. But actually our epidemiology is not that precise because of the challenges of diagnosis. And of course, unfortunately, fatalities are still seen, and that's what we need to work to prevent. So this was a newspaper article that appeared in the UK press some time ago about a baby who was known to be milk allergic, who was accidentally given a bottle of cow's milk in the nursery, which led to their death. And there's been a number of publications over the years about fatal anaphylaxis. And these are quite useful studies as they point out why patients die and therefore what we might be able to do to actually prevent that from happening. So let's think about the pathophysiology of anaphylaxis. So you have a mast cell basophil with specific IgE receptors to an allergen. And let's just assume that this is a peanut allergen. So this is IgE that's specific to bind peanut. So the peanut allergen binds to the mast cells in the tissues or basophils in the circulation. And these IgE molecules cross-link, and that activates the cell, so you get degranulation of the granules, and that releases a whole load of inflammatory mediators, in particular histamine, but also prostaglandins and leukotrienes. So these mediators are what leads to, firstly, the early phase, and secondly, late phase symptoms. And I want to talk about those in a little bit more detail now. So early phase symptoms. So this is what you see in the first few hours after the onset of reaction. And they typical things, so cutaneous manifestations, so urticaria, angioedema, or pruritus. Vomiting is the way our body has got of actually removing allergic substances, and that's a typical early reaction. May have eye or nose involvement, and at times you may get respiratory involvement, either upper or lower airway, or circulatory involvement with low blood pressure, and this is when you're starting to get into anaphylaxis. So those are the early symptoms. What happens though are all those inflammatory mediators attract inflammatory cells into the environment. So T cells, the eosinophils would be some examples, and they then cause these late phase symptoms. And the late phase symptoms are very similar to the early phase ones, except they occur sort of 6 to 24 hours later. So a patient can get better, then they can start developing late phase symptoms, be it cutaneous, gastrointestinal, lower respiratory, or upper respiratory. And these can be severe, particularly the respiratory ones. So I mentioned anaphylaxis is more of a syndrome than a diagnosis, because different patients have different presentations, and actually a patient can present in different ways with different allergens or even the same allergen. And you can go really from the head down to the toes in terms of manifestation. So dizziness, eye involvement of itch, runny nose, hoarseness, difficulty in swallowing, wheeze, chest tightness, cardiovascular involvement with low blood pressure, nausea, vomiting, colicky pain, etc., etc. So, and this is one of the challenges in terms of making a diagnosis, because actually the presentation can be very varied between people. So in terms of management, we need to know, is it anaphylaxis, or is it a severe allergic reaction, or is this just a mild or moderate reaction? And the key thing there is airway involvement, airway, breathing, circulatory involvement. If there's no involvement of those, it's going to be mild or moderate. If there is, it's anaphylaxis. So tightness or lump in the throat, shortness of breath, cough, wheeze, circulatory issues. And so this is the key differentiation. So I'm now going to move to talking about which patients are at risk of developing anaphylaxis. Unfortunately, this is not black and white. This is very much a gradient between those that you can be certain are at risk and those that you can be relatively certain aren't at risk, but actually a lot of people are in the middle. So absolute indications for adrenaline autoinjector is essentially previous anaphylaxis, and that might be triggered by a food or latex or medication, might be exercise induced or idiopathic. Then there's a group of patients who have a coexisting unstable or severe asthma. And that group we think are probably at more risk of having severe reactions. Then you've got specific allergens that seem to cause anaphylaxis, particularly Hemoptera venom. And then conditions that mean that you're more at risk of anaphylaxis, and the example here is mastocytosis. So there is a box where most people would agree that actually those patients are at risk, at high risk of anaphylaxis, and should have access to self-injectable adrenaline. Then there's a whole load of other risk factors which are associated, be more likely to have anaphylaxis in the future, but not to the extent of this white box here. So what are they? So there are a few other allergens that seem to be associated with severe reactions. So I'm thinking of peanuts and tree nuts, cow's milk, seafood, and some of these are very geography dependent. Then you get different types of patients who might be more at risk. And we know teenagers tend to take risks, test the boundaries, and we think that they are more at risk of having a severe reaction than other patients. And that, then if you're remote from help, it may take you a while to get access to self-injectable adrenaline. So maybe that's a group of patients who need to have their own. We do get concerned about reaction to traces of food, although the literature relating amount of exposure and severity reaction is certainly not consistent or agreed on, but that might be an indication of that actually you should be giving an autoinjector. So systemic reactions to Hemopteras that aren't anaphylaxis. And then this oral immunotherapy for food allergy. Some people might say that this is a definite indication. In the guideline we published a little while ago, we had it as a relative indication. So these are the sorts of things that actually you should be thinking about, asking about, and they may or may not push you into prescribing an adrenaline autoinjector. I think the thing to say is this should involve a discussion with the patient and the family, and it may be that particular issues or particular considerations with a particular patient or family mean that you should. But some families may just not want to be carrying an autoinjector around. So I would suggest that this is a shared decision. So why use adrenaline? As adrenaline has two key pharmacological effects. First of all, it's beta adrenergic stimulation, and that's good because it speeds up the heart rate. It makes the heart contract more strongly. So if your blood pressure is low because of peripheral vasodilation, it will hopefully to some extent restore blood pressure. Beta adrenergic stimulation also gives bronchodilation, which will reverse some of the lower airway issues and potentially can reduce the release of inflammatory mediators. The other reason for using adrenaline, and this is where it wins over bronchodilators like salbutamol, is the alpha adrenergic stimulation. So with anaphylaxis, you get peripheral vasodilation, all your blood vessels open up. So you got reduced peripheral vascular resistance, so your blood pressure drops. So by this alpha adrenergic effect, you reduce vasodilation, improve the blood pressure, improve cardiac perfusion, and also reduce angioedema. So adrenaline is actually a drug that, because of its multiple impacts in the body, is very good at reversing all the key pathophysiological changes seen in anaphylaxis, and that's why it's the drug of choice. How should it be given? So this is a very old study, probably never going to be repeated, comparing intramuscular and subcutaneous adrenaline in children. And as you can see, the children who got intramuscular adrenaline had a much higher peak than those who were subcutaneous. So this is what has led us to recommend and continue recommending intramuscular adrenaline for the treatment of anaphylaxis. Adrenaline does have side effects, and these are the typical ones. So the sort of flight or fight type response of anxiety, fear, tremor, restlessness, etc. There are some side effects that are much less frequent, I would say very rare, but that should be considered, particularly in older people. So arrhythmias, angina, myocardial infarctions, pulmonary edema, etc. These you're very unlikely to get with intramuscular adrenaline, much more likely if it's given IV, and that's another reason why we emphasize that the adrenaline should be intramuscular. Now, so these minor adverse effects are frequent, but actually they're quite useful because they can reassure a patient that they've correctly used their adrenaline autoinjector and they have adrenaline in their system and it will be treating their anaphylaxis. So you can turn a potentially negative adverse effect into something that's actually quite positive and reassuring for your patient. There are a number of different autoinjectors on the market. These are just a selection. There are others. I picked them because they are the ones available in the UK for us to prescribe. They all work slightly differently and they have different pharmacokinetics, and I would recommend that you look at the devices available in your country, have a look at the pharmacokinetics and decide which one or ones are best suited for your patients. Every now and again, there is a recall of these devices, and so it is helpful that there are multiple devices on the market so patients can be switched if necessary. What I need to emphasize though is that they all are used slightly differently. So if a patient is switched to a new device, they need to be trained to use that device. So sometimes adrenaline isn't successful, and there are usually some obvious reasons for this. So if you say have a venom hypersensitivity reaction, that's a very rapid onset, very severe, and intramuscular adrenaline just may not work. And similarly, if you've reacted to an intravenous medication. More frequently, adrenaline doesn't work because it's simply given too late or given by the wrong route. Adrenaline degrades with time, and so and this is why adrenaline autoinjectors have a fairly short half-life. Drugs do antagonize adrenaline. The obvious one is beta blockers, but also ACE inhibitors, and they will reduce the impact of an IM dose of adrenaline. And then there's preservatives in the medication. The usual one is metabisulfite, and occasionally you get a patient who's allergic to that. So giving the autoinjector just precipitates another allergic reaction. So these are the normal things that cause failure. So how do you manage anaphylaxis? And so this includes both self-management and medical care, because most of these episodes occur in the community, and we need to train up the patients to manage. This is taken from our recent anaphylaxis guideline, which published in Allergy, and this was an EACI task force. And I'm going to just take you through this in a little detail. So first of all, is it anaphylaxis? And so suspect anaphylaxis. This is acute onset, life-threatening, and there's mucosal or GI symptoms. Now, the key thing here is probably about 1 in 10 cases, you will not see these. And actually, it's an airway, breathing, or circulatory presentation. So you have to have quite a high incidence of suspicion, particularly in a patient with a history of previous reactions, particularly if it's anaphylaxis. So these are sorts of symptoms you might see. And I would say you should have a low threshold for assuming it's anaphylaxis and treating on this pathway. IM adrenaline rarely causes any important side effects. So the treatment of choice is IM adrenaline, and there's doses for children and older children and adults. And we put here the dose of the auto-injectors because that's the easiest way to give this. And most of the auto-injectors are either 0.15 or 0.3 milligrams. There are other things that are important to do, so calling for help, removing the trigger, and then optimizing posture. So if the presentation is mainly respiratory, sitting up the patient with elevated legs is what she should be doing. If it's cardiovascular, the blood pressure is likely to be low, and then the patient needs to be laid flat with the legs elevated. And what we've learned over recent years is actually even with respiratory presentations, cardiovascular system is compromised, and particularly young people are very good at compensating for marked peripheral vasodilation, and so elevating the legs and improving circulatory return to the heart is a very good idea. So, okay, so we've given some adrenaline, we've called for help, etc. There are a few other things you can be doing where you're waiting 5 to 10 minutes to see if the patient's going to respond to adrenaline. So we'll just mention fluids. So any circulatory presentation or a severe respiratory one, we'd recommend giving fluids. Stridor, nebulized adrenaline as a supplement to IM adrenaline is useful. If it's lower airway, a beta agonist may also be useful. But the key thing after 5 to 10 minutes, if the adrenaline hasn't done the trick, to give some more and give some IV fluids. Why 5 to 10 minutes? Well, we know from the pharmacokinetics that it takes 10 minutes to you achieve peak plasma levels of adrenaline after an IM injection. It may, though, be obvious at 5 minutes that you need another dose, and so that is there as a range. So, having repeated the adrenaline and given some IV fluids, it may be that actually they still aren't recovering, and then you need some intensive care support. Because essentially what's required there is an adrenaline infusion. So there's a few things to think about once the patient is stabilized. So first of all, checking the diagnosis, and so mast cell tryptase can be really helpful here, particularly in adults. There may be some additional treatments, so antihistamines to make the patient more comfortable. Corticosteroids come off this, and they may actually be suboptimal, deleterious in children, possibly in those who've got asthma, possibly adults, maybe they should be considered and given. And then, of course, you need to think about how long to actually observe the patient. Essentially, the more severe the presentation, the longer they should be observed. And with cardiovascular presentation, definitely for 24 hours. So that's the approach to managing anaphylaxis, and you can find more details in the guideline. In terms of self-management, obviously this needs to be a little bit simpler, and it's important that patients have a personal action plans, and they train to actually be able to deliver that care. And this training needs regular reinforcements. So patients need to be able to recognise an allergic reaction, what severity it is, and how to manage different reactions. And for younger children, that obviously involves training carers. And they need to be carrying their adrenaline autoinjector. So this is a self-management plan that the British Society has generated. This is for children, and we're currently working on an adult variant. So mild, moderate reactions, essentially antihistamine, but actually also watching, waiting, informing parents, because this, of course, can turn into this over a period of 10 minutes, half an hour, maybe even 2 hours. So anaphylaxis, so this just reminds patients and caregivers of the presentations and what to do. So sitting up, lying down, giving adrenaline, and calling, in the UK, 999 for an ambulance. And then what to do afterwards, particularly giving a second dose, and erring on the side of caution here, so after 5 minutes. So that's British plan. There are others from different countries. It's in the UK, we try and have one plan for children, so schools and nurseries are familiar with what it looks like, and that hopefully helps them to be used reliably. So that's all I wanted to say about self-management plans. So that leads to a conclusion. So I've talked about anaphylaxis as a severe life-threatening systemic hypersensitive reaction with both early and late phases. I've talked about any airway, breathing, and circulatory issues being synonymous with anaphylaxis, and really in an emergency, erring on the side of caution and assuming anaphylaxis. The patient can always be assessed in clinic later on, and a conclusion got to, but if there's any possibility it's anaphylaxis, the patient needs to be treated as anaphylaxis. I've emphasised intravascular adrenaline is the treatment of choice, and provided you some details as to why to justify that. And I've also emphasised the need for education and training of patients, because the chances are that the next time they experience anaphylaxis, it will be in the community and they will need to be able to self-manage it. This is the graphical abstract from our recent anaphylaxis guidelines. It's the underpinning evidence for the guideline is published in a systematic review in the same year with first author Deborah De Silva, who's a methodologist who supported that work. Thank you very much for your attention.